first one we're gonna take is, Senator Deeds' bill because, I'm sorry, Senator, Edwards' bill because he has some folks here who, we need to give the opportunity to speak. And somebody's supposed to be getting it for him. Let me go get it. Here he comes. Let me just announce while he's right next door, he's working his way over here. Let me just announce while we're doing that, in case anybody's here for Senate Bill 1049 or Senate Bill 1050. They'll be going by for the day,
So will 568.
and so will Senator Donovan's 568. Oh, I'm sorry, 1049 and 1050. Senator Edwards, you're up.
Okay.
This will be Senate Bill 564.
Senate Bill 564, Mr. Chairman, members of the committee, is designed to expand the responsibility of the advisory committee of the Virginia Hearing Loss Identification and Monitoring System to include selected language development milestones for educators and early intervention specialists for use in assessing language and literacy development of children from age of birth to age 5 who are deaf or hard of hearing. The bill requires the addition of at least 2 language experts to the advisory committee. The bill also requires the children. The bill also requires the children identified as deaf or hard of hearing in special education programs be evaluated yearly on the basis of language development milestones established by the advisory committee. There's some people, the trustee here. Trustee? She can explain it further.
Sure.
It's a fairly simple bill that I said deals with the advisory committee.
Hello, my name is Trisella Bateson, and I am the chair for the group that is proposing this bill, so thank you for sponsoring us, Mr. Edwards. This is our 4th year of presenting some sort of legislation to benefit children and their language development. We've been really frustrated so far. I believe that no one in the community understands the issues, and as a deaf person, I understand them very well, especially in the education system, and seeing adults that have gone through the system, and it's not very. Language deprivation is common, especially in our community, and language delay or more. So that's why, again, we're here with a simple version of the bill, and we're asking the committee to expand, the EDHI committee to expand and assessing language to make sure that children have the language development they need. And we want to select the milestones in English and ASL. Last year, we proposed a bill to the JHCC and Joint Commission on Healthcare. Then the bill was PBI, and we had collected data and research and had a collection of information and proposed it to the committee with different options. As well, we had public opinion. We had 239 public comments received and 275 supporters, and out of 128 people, we had the support. I'm sorry. Out of 128 comments, 151 supporters. We had a small percentage against it. I believe the people who were opposed did not understand the issues. They were not professionals. They weren't speech therapists. They weren't people who have walked in our shoes and have seen what we've seen. They don't have the culture and the social aspect that we have. A high percentage have depression as a result of cognitive, the impact of cognitive language deprivation, and the higher suicide rates and unemployment. And it's a health issue that needs to be addressed, which is why we're asking. It's a very important issue we'd like to see solved.
Thank you. Senator Edwards, let me ask you something before we get too deep into this. I've been around long enough to know we've had a lot of these bills over the years, and some have generated a great deal of controversy. Has this one got a lot of heat that's going to be associated with it, or?
Well,
I know that there are some people who might be opposed for our previous bill, and our goal is to have ASL recognized for its language milestones, and I believe that the public comments that you hear are going to verify that.
Senator Edwards?
yeah.
I think you've don't want you to set us up for a all-day event here, so.
No, it's a fairly simple bill. It basically requires the milestones to be established for children aged 0 to 5 about their language development, their in terms of those that are hard of hearing or deaf milestones. Secondly, it requires experts in sign language and also in the use of oral English.
Okay.
And so it's really very simple. And I think the opposition, I can't, they can explain themselves, I guess.
Okay.
So,
All right.
but you see what Joint Commission on Healthcare did in terms of public comments, they were widely supported with the public comments, and there's people here that can explain their.
What did the commission do?
They did really well.
Mr. Chairman, I
Senator Donovan.
I think that the commission decided that there was not enough evidence to choose any of the options that were considered in the Joint Commission on Healthcare to recommend by the commission. And just as we go forward on this, because we have invested an enormous amount of effort in trying to find a way to work this out, both here at the legislature and at the Joint Committee on Healthcare, I think based on my past experience, and I'm trying to sort through it now, but I believe there are two really important issues. One is that children who receive cochlear implants will not develop language as effectively if they've learned sign first. And so anything in the bill that would interfere with their ability to develop that language, which is the desire of the parents, would be a conflict in the bill that wouldn't work. The second issue has to do, I think, with these milestones. There are many states that have developed their own milestones. They're having a difficult time developing nationally recognized milestones. There's a lot of expense and investment in tracking those milestones, and I think that's an area where we need to have consensus before we legislate. So as we go forward and hear from people speaking to the bill, I think those are two particular issues that are at the crux of why we can't find a bill that move forward. And I can tell you, we all desperately desire to make sure all children with language challenges can succeed in Virginia, and that we support that. But we have to find a bill that's built around consensus and best clinical evidence.
I think the evidence tends to show, from my perspective, that there's different kinds of people who are deaf and hard of hearing. Some are completely deaf, and they're not, and implants and the like, it's not going to help them. They're just totally deaf. And then there's some people that implants can help a lot. But the point is, there's many ways to help people who are deaf and hard of hearing, not just one. And this is a start to develop milestones that maybe they're different milestones, but anyway, get started on that. And then also have experts, some people, they need to learn sign because they're going to be deaf. And whether you have implants or not, because they're not going to, they need to have, I've been around deaf people enough to know that signing is very important for an awful lot of these people. And the second is learning to track people's lips.
Sure.
Learning to
All right, well, let's
learn English that way.
let's start hearing from you folks, because we've got other bills and we've all got other places to be. I'm not trying to short shrift anybody, but this is an issue we've spent a lot of time on over the last couple of years.
Okay. Hold up.
Trying to get these folks lined up.
Sorry. I also have my cranky baby with me who just got up, so let's see if she'll let me talk here for a moment. But I am here because of her. Here, I can juggle more. You guys are pardon me just a second. It's okay. She can stay with me. I'll do it. Okay, all right, let's do this. Sorry, everyone. And this is why I wrote down a few notes. All right. It's okay. So I would like to just quickly address you all as a parent of a deaf child who uses a cochlear implant, a hearing aid, sign language, and spoken English. And so I want to, as politely as I can, say that I strongly disagree with there's certainly not consensus that signing delays or impacts in any negative way cochlear implant success. My daughter has been very successful with the cochlear implant and sign language, but I'm not really here to debate that part right now. I really instead want to speak to the bill real quickly and say that I think in regards to your concerns there regarding controversy with the bill, that this is a much, as Senator Edwards said, much simpler version of the bill. I wish it had more teeth, but it doesn't. And so this bill is, I think, a lot simpler than in past years. I think both have had some of the things from the previous years, but it has been changed in order to try to make this, I think, more passable.
We'll find out shortly.
Yeah, so what I will say with that is that I don't see how tracking and establishing language milestones is particularly controversial, and that information is pretty powerful. And so with tracking and having milestones set, it just gives us information so that we can intervene. Because if we don't find out until kindergarten that we do have deaf and hard of hearing children that are language delayed, it's too late then. This is not really debatable research, right, that 90% of brain development happens by 5, and a vast majority of that in terms of language is even birth through 3. And so we really want to take advantage of that critical window. And so, like I said, my daughter uses a cochlear implant. It is a tool that works fantastic for her. She is developing spoken English and sign language side by side. But it doesn't work for everyone, and if there is a delay, we want to be able to have that information and intercede. The last thing I want to quickly say is that this bill adds in something that previous bills I don't believe had, which was the special education supports. As a former teacher and as a parent, I'm really excited to see that this bill kind of gives a little bit more backing to parents navigating the special education process with their deaf children.
Okay.
Thank you.
Senator Edwards, who's next?
Who's next?
So I just want to make a quick comment about.
Say who you are.
Yeah.
I'm sorry, my name's Patty Harris, and right now I'm a VCU student going to be a master's in special education. So I've been studying language deprivation quite a bit, and we have watered down the bill quite a bit. And we actually, our opposition created a bill 2 years ago with the exact same people that are on this committee now, and we're just asking you to add 2 language specialists, because the whole point of EHDI is to track hearing. And why are we tracking that they hear? So they have access to language. And if we're not tracking language, then what's the point of that? I feel like the language development is very key. And it doesn't matter what language you're going to use. I think the 2 languages that are used the most in the deaf community is spoken English and American Sign Language. So I feel like bringing ASL up to equal level as spoken English is fair and a human right for deaf children, and so that is the only comment I wanted to say.
Okay, thank you. Yes, ma'am.
Hi, my name is Catherine Malady. I live in Richmond, Virginia. I just wanted to speak to the bill and your concerns about the controversy. Really, right now, there's early intervention services and preschool services for children who are deaf and hard of hearing. A requirement of those services is to be able to assess language. Right now, the system is set up to be able to assess spoken English. For children who choose American Sign Language, the system has no resources to assess that. So professionals of the state who cannot complete their duties as assigned, they cannot assess sign language of the children. I think that Nicole could speak to this, the mother who was up here before, how hard her team has had to work to find the resources because the state doesn't have that. So we're not forcing anyone to use sign language. If they only want to use listed and spoken language with a cochlear implant, it's their choice. For the families that choose ASL, we want them to have the resources that they need. Nothing in this bill forces a family to choose any specific option. We are just trying to provide resources to the families that don't have it.
Okay, thank you very much.
Thank you.
Anybody else speak in favor of the bill? Please, don't do that, please. Okay.
You're raising hands.
All right. Anybody speak in opposition to the bill? Anybody? Well, Senator Everett, you appear to have been right. Absolutely no opposition to the bill. Well, this is a miracle. Okay.
There's more ways to a conclusion than just one way.
Okay.
Different people, like, if cochlear implants and so forth is the way, that's fine. But there's some that need the other approach as well.
Does anybody have any questions for Senator, anybody on the subcommittee have any questions for Senator Edwards? All right. We move by motion around here.
I'll move to approve. Second.
It's been motioned and seconded that Senate Bill 564 be recommended for reporting to the full committee.
I'm always good.
Nice try.
I can't remember.
Trying to sneak an extra vote in, are you? All right, and the motion is before us that we recommend reporting Senate Bill 564 to the full committee. All those in favor say aye.
I'm gonna say aye, and Suderline's gonna abstain because he wasn't here.
Okay, that makes sense. Good.
All right.
All right, Senator Edwards, thank you. Now we'll go to the sign-up sheet. But the only person on the sign-up sheet, are there two people on the sign-up sheet? Yeah. Is it okay? Pillion's on the sign-up sheet. Or Pillion. You're up. Senator Pillion.
Committee, what we got for us? I have two bills, if we can take 864.
Go to 864 first.
So it's basically, in 2017, you may remember that Delegate O'Bannon at the time passed a comprehensive harm reduction program, pilot project that had a, that's not great, that had a.
Time's up.
Time's up. Regardless, I'm saying, that had a three-year sunset on it. And I'll be honest, at the time, I was not supportive of this legislation. I have since then been convinced, because two of the most successful programs are within my district. And some people actually came from Southwest Virginia today to speak on the success of those programs. But there's 4 current programs in the Commonwealth. This just repeals the sunset, so we can continue with the great success of this program.
Okay, great. Let's hear from the folks in favor of 864. Yes, sir. State your name and.
James Tyler, I'm the CEO at Smith County Community Hospital in Marion, Virginia. Smith County Community Hospital several years ago got together with several other entities within the county to form a coalition to try and address the substance abuse issue in Smith County. It is a very pervasive problem there, and something that I see all too real in my emergency department day in and day out. One of the things that we decided to do with this coalition was we had the Sheriff's Department, Chief of Police of Town of Marion, several other entities, Health Department, Community Service Board, and the like, that came forth and were part of this coalition. With that, we looked at and did our community health needs assessment, and the #1 problem from the community itself was trying to deal with substance abuse. And so we decided to take a multi-pronged approach to it. The hospital was able to get a grant from HRSA for $745,000 over a 3-year period of time to have navigators in our ED to help assess those. One of the other things that we were concerned about, and this came from Sheriff Schuler, was the amount of needles and the like that his officers were finding at any given time when they were going out and doing investigations. It became very prominent. One of the things that they used for a sharps container was this. Not very effective. Needle can poke through that pretty quickly. So the hospital, with Ballot Health, paid for all police officers to have a sharps container in their car. We taught them how to use it properly. We taught them infection control techniques to minimize their ability to have any kind of untoward needle sticks. As a result of that, we went before the County Board of Supervisors and we requested in August of 2018 that they approve the Comprehensive Harm Reduction Program. We gave them 1 month to think about it, and the rationale for that was they weren't going to call me, they were going to call the Board of Supervisors, members of the general public. And so after that month, we came back in September, the board unanimously approved it. The whole focus of this was to try and protect our folks who were the police, EMS, all those folks who were going to these places and the potential of them getting stuck. You see the information here as far as the frequency of hepatitis B, hepatitis C, and HIV. All of these things we are dealing with. And so as a result of this program, we've been able to successfully get 115 participants. We're getting a 97% return rate on the needles that are given out to them. Ballot Health provided a grant to the health department for $25,000 to renovate space to have a clinic there in which all these activities occur. And so I speak in favor of this bill today. Are there any questions?
We'll get to that in a sec.
Sure.
Next.
Hi, my name's Lori Delano from the Virginia Department of Health. The administration strongly supports the bill.
Great.
May I
Yep,
question?
Senator Donovan.
Just a question for this program in my district. Are there any immunities that individuals have when they're at these centers?
The participants,
Mhm.
That's not my understanding, no. There are protections for staff members who staff the programs, but not. Is that right? That's correct, isn't it?
Have you had any trouble with that? There's a little bit of trouble in my district about that. I'll talk to you
I'm
about
gonna
it
bring up
offline.
Elaine
Okay.
Martin. She's in our Division of Disease Prevention, runs our HIV prevention programs, including the comprehensive harm reduction programs.
I've had from some constituents that there, Mr. Chairman, sorry, that there are participants that are reluctant to go because they feel like there is some law enforcement that tends to be nearby and that they're in jeopardy of being arrested.
We have, the programs can only operate where we've got law enforcement buy-in, and so you've got to have a letter of support from law enforcement and city council before a program can be authorized. So, the current 4 sites, we have not had any complaints about citizen arrests by local law enforcement. Participants are given an ID card, so they can show they belong to a program. It doesn't offer them legal protection, but if we have cooperation with law enforcement, they have been working with us to ensure that folks can come and go as needed. But so far for the 4 programs in operation, we have not had any complaints about that.
And Mr. Chairman, Senator Donovan, this bill keeps that in place.
All right, great. Any questions of, oh, yes, ma'am.
Just Jennifer Basin, Executive Director of the Virginia Association of Community Services Boards in Wisconsin.
Sure, okay. Any questions for Senator Pillion or anyone who's testified so far?
Move to report.
Mr. President, second.
Senator Barker.
Just a comment. I'm on the State Substance Abuse Services Council, Advisory Council, and we've looked at this issue, and it's just been phenomenal in terms of the success of the program. And as a result of that, what has happened is a lot of law enforcement people and others in local communities have totally changed their positions. So from what they're initially very hesitant, but once it was demonstrated, this is something that's needed to be able to address some of the issues in that area. So,
Just by chance, would anybody want to speak against 864? Good. All right, so I think
You're
you
not
make a
gonna
motion.
speak up. I move to report, yes, sir.
All right, got a motion.
And
Senator
I
Barker
second.
seconds to report 860, recommend reporting 864. All in favor say aye. Aye. Opposed? No. Okay. Good enough. Senator Pillion, what you got next?
So the second bill, 863, follows the same genre. It authorizes the governor to lease a portion of property that's currently on the Southwest Virginia Mental Health Institute that's been empty for a number of years, back to a group that's been created by a group of local stakeholders called the Appalachian Center for Hope. And this group hopes to place a residential female transition, substance abuse transition.
So this is just giving the authority to
This will give the
lease.
authority to move that property, to lease that property
Okay.
in the state.
Have you got anybody here on this one? Anybody for 863, Senate Bill 863, Senator Billions bill?
I do have 9 localities in Southwest Virginia that have written resolutions to support this project.
Yeah.
And I know if it does meet your favor today, it will have to go to finance for their review.
Full committee will do that.
Yeah.
Right, okay. All right, so I'm sure Senator Dillman's got a motion on the tip of her tongue.
Yeah, we'll move to report.
And I'll
Refer.
second, and that will be the motion, is to recommend reporting to the committee and re-referral, I suppose, if that's appropriate, to finance. All in favor say aye. Aye. Opposed? All right.
Thank you, Mr. Chairman.
Senator McClellan is next on the sign-up sheet. Hello.
I have Senate Bill 712, which is essentially a Pregnant Worker Fairness Act. Add substitute, yes. While the substitute is being passed out, basically this bill would combat pregnancy discrimination, promote public health, and ensure full and equal participation and opportunity for pregnant workers in the labor force by requiring employers to provide reasonable accommodations to employees with limitations related to pregnancy, childbirth, or a related medical condition, so long as that's not an undue burden on the employer. This is basically to give teeth to, we have an anti-discrimination statute now that applies to pregnancy, childbirth, or related medical conditions, but the only thing it really does is say that you have a cause of action if you get fired, but that's it. And so where pregnancy discrimination really occurs is where a worker requests a reasonable accommodation, usually at the request of their physician, and the employer either refuses outright or won't consider it, and sometimes there's been retaliation in response to that. And this basically does several things. One is it would first, the Division on Human Rights would develop instructional materials and engage in educational efforts to inform employers, employees, and applicants about their rights and obligations under the Pregnant Worker Fairness Act. It would create a private cause of action if an employee is denied a reasonable request that is not an undue burden, or if they're retaliated against for requesting an accommodation. It makes it unlawful, well, actually just moves the current prohibition on firing an employee on the basis of pregnancy, childbirth, or related medical conditions from the existing Human Rights Act, and sort of creates a separate section to cover pregnancy. And that's the gist of it. If you have any questions, I know there are several people who want to testify, at least a couple of different groups.
Do you create any presumptions in here? Are there any presumptions in here? I'm just asking, I don't know.
I do not believe there are presumptions, but let me verify that. Let's see.
I don't seem to see them either, but.
No, I think the meat of the bill is starting at line 98. There are not any presumptions.
Okay. Any questions of Senator McClellan before we start taking some testimony here? Anybody to speak in favor of Senate Bill 712?
Hello, I'm Jessica Lee. I'm a staff attorney and researcher at the Center for Work-Life Law, where my work focuses on preventing discrimination against pregnant and breastfeeding workers. The center provides a legal hotline for employees who feel they're facing discrimination, as well as providing assistance to employers to help them understand their legal obligations. We hear from employers all the time who simply also trains attorneys. I can tell you that the legal text under the law is very confusing, sometimes even for them. So it's especially confusing for those employers who don't have in-house counsel, and we know that's most of our folks. When employers, for whatever reason, don't provide reasonable accommodations for their employees, their pregnant workers face a terrifying choice. Do they keep working and earning the income that their family needs to put food on the table and roof over their head? Or do they stop working to protect their health and the health of their pregnancy? Workers who don't get the reasonable accommodations they need experience excruciating pain. They're hospitalized with severe infections. Pregnant workers who aren't provided reasonable accommodations give birth to their babies too early, and some even face birth defects as a result of toxic exposure in the workplace. All too often, pregnant workers whose employers ignore the risks suffer miscarriages. Existing federal laws and the Virginia laws that mirror them are just not enough to keep these workers safe and earning income. There are just too many gaps, too many gray areas, and too much legal interpretation needed to get it right when it comes to these very important matters of health, life, and death. Virginia's pregnant workers need an enforceable and clear law to keep them safe and earning an income, just like pregnant workers in our neighboring states, Kentucky, West Virginia, and South Carolina have. Thank you.
Next.
I'm Nicole Tortorella, the Women's Rights Advocacy Council at the ACLU of Virginia. We also support this bill, and just wanted to provide some context. 27 other states, including our neighbors, West Virginia, Kentucky, a little further south, South Carolina, have similar legislation on the books requiring these accommodations. So Virginia would be joining the growing majority of states passing these laws and requiring these accommodations. It is also a workforce participation issue. Studies show that providing reasonable accommodations improves recruitment and retention, reduces absenteeism, and improves workplace safety. So in addition to all of the benefits that Jessica was saying for the pregnant workers themselves, it is also an issue that helps businesses. And I was also asked by the respective organizations to note that Birth and Color, RBA, NARAL Pro-Choice Virginia, A Better Balance, and the National Women's Law Center are all also supporting this bill. Happy to answer any questions, but thank you.
Next.
Good afternoon, members. My name is Ali Farouk. I'm here for Families Forward Virginia. We're the state office for 2 of the national evidence-based home visiting programs in the state, including a state one called CHIPA Virginia. We serve moms and parents as young as prenatally all the way to age 5, and we serve a lot of young moms who are struggling with these issues, and for that reason we support the bill.
Next.
I'll speak quick. My name is Kenneth Gilliam, representing the Virginia majority. Just want to register our support for this bill as well.
Alrighty, anybody here to speak in opposition of Senate Bill 712?
Mr. Chairman,
Senator Dunham.
So obviously this is my district, and I write notes all the time for people to be out of work. I am certain that there are some extraordinary circumstances where there have been injustices that happened with pregnant women. I find the scope and the detail of this bill too far-reaching for something that I can support. I think, are we going to do this for every medical indication, that we're going to write exactly what the criteria are and what each example is of bathroom breaks, etc.? I think that it would be, I think we have protections that my patients have exercised for discrimination. They certainly may need to be shored up. I think you could certainly say that a reasonable request from a doctor should be met unless there's a hardship with the business. But the prescriptive detail in this bill just seems an extraordinary overreach, creating undue regulation and conflict, and I will not be able to support it.
So I would note this is very similar to legislation that has passed in other states that they have found actually helps to reduce their litigation costs, because usually what happens is where you have lawsuits occurring is where reasonable accommodations were provided for men with obviously non-pregnancy related health issues, but when a pregnant woman requests these accommodations, she's not provided them. I'll give you an example of how complicated it can be. When I was pregnant with my first child, I work at Verizon, and we were in the midst of doing contingency training in case there was a work stoppage. I was initially given an assignment of being a lineman, which meant I would have had to go through training to climb telephone poles and do all of these things. Now, Verizon is a multi-state company that it had to go to the head of HR and have the HR lawyers to sort of tell him, based on federal law and what the laws were in other states, and then trying to be consistent with all these other states, you're gonna have to find a different assignment for her. And based on, it took a long time for them to do it, they did it, but that's a Fortune 500 company with a whole lot of lawyers who could educate the head of HR on this. Not every workplace has that, so I think at a minimum, providing the training and the education materials to help them understand why you may need to make accommodations, what reasonable accommodations would or would not be, is something that is necessary. And right now, all women can do is if they get fired, they have a cause of action under Virginia law, but that's it.
Mr. Chairman.
Senator Donovan.
I think it would be very reasonable to give guidelines for businesses about what they might need to look at and what the issues and legalities are. I'm trying to see if I passed this off to him or if I kept it. This is bill number what?
712.
Can I have the substitute again? Because I gave it to, thank you. So, I mean, I think absolutely, having guidelines and educating business, I would suggest to you that the size of that business is part of the reason it was so difficult, because it was such a common sense decision that a pregnant woman shouldn't be climbing and being a linesman. And in fact, I've had a linesman for Dominion who was put on different work duty immediately when she was pregnant. So I think that we can't legislate every piece of common sense that exists, and that certainly having guidelines where you were say, these are best business practices, these are legalities, these are how it should be. I would be curious to see what the other states have, because I would be curious to see if they were as prescriptive as this legislation is. But having guidelines for women to know what their rights are, for businesses to know what their obligations are, and having a general language that says that there are consequences if reasonable accommodations are not made is a reasonable piece of legislation, and this exceeds that extraordinarily.
Well, if you have suggested amendments, I'd be happy to talk to you about them, and the fact that no one has come to me and said this is too broad or asked for amendments or anything like that suggests to me it's not too complicated.
I would move the bill be reported. We need to get this thing.
And I appreciate that, and I'd be happy to talk with you.
Senator Sasslaw has moved the bill be reported. I'll second it. And so, with the recommendation that it be reported, all in favor, say aye.
Aye.
Aye. Barker votes aye.
I will abstain for now.
Thank you.
Would still be all positive. We've got to strike all that language.
Okay.
You doing all right?
Sounds good. Senator Cates. And then Senator Lott.
If you want me to talk, I can. If not, I can.
Oh, I'm sorry.
I'll put it on.
Yeah, there he is. Okay. Senator Higgins, you've got Senate Bill 397.
Yes, I do. So, Mr. Chair and committee, I'm here to present Senate Bill 397, which is about nursing home standards of care and staffing requirements. And basically, this bill does three things. Oh, I'm sorry, I have a substitute we need to talk about first. I guess we'll present the substitute.
I'll move the substitute.
All right, second. All right, all in favor? Aye, aye, aye. Substitute supports.
And Mr. Chair, what the substitute did was just take out, there was some verbiage about hours requirements. We took that out and left the staffing ratios piece and some of the education pieces. So speaking to the bill, and it's on page, starts on page 7. Again, this bill and the substitute does 3 different things. It defines the staffing ratios 6-to-1. It requires background checks every 5 years for staff, and then also requires quarterly staff training in first aid, medication administration, nursing home policies. So I just want to speak to the bill in general. So I think we can agree that the aging of America is here, right? We've got more people living longer, doing better, but we've got a lot of, because they're living longer, we've been able to keep people alive. We've got a growing nursing home population, so they're living longer, requiring more health care. We're doing more surgeries, or requiring more rehab care. So our nursing homes are full. These are geriatric patients who often don't have a voice, their families as well. So we are here just to advocate for them and also for the staff. I've been a geriatric nurse practitioner for 7 years, and I've worked in rehab and nursing facilities. I've seen and been with patients who just can't have their needs met because there's just not enough staff there. You could say that the issues boil down to retention and recruitment. We can't hire people, we can't keep people, but there's a reason why, and working in those jobs, they're very demanding jobs, they're not often well paid. We can do better than what we're doing. The problem is only going to get worse from here. But these are patients that can't get to toilet by themselves. They call for staff, they call for help, they have no choice, but to toilet themselves. They can't make it to the restroom, they can't feed themselves, so they said they'll be delivered trays of food, but have to look at it and can't eat. These are people who will fall out of beds, oftentimes injuring themselves, and can't even get to the call button to call for help. They can't get their meds on time. All of these issues just create more acute issues that then require hospitalization. Once we send them to hospitals, they're a lot of times bound for failure there in this older, frail population. And then you talk about healthcare costs, that just really adds to the healthcare cost problem. So I'm here to advocate for my patients, for their families, and also for the staff. I think we can do a better job. The staffing ratio piece that's in this bill, there's maybe different ways to skin the cat, but this is absolutely one of them. If we have more caregivers per patient, obviously it's going to reduce the workload for our caregivers and be better for our patients so they can have their needs met on time. Our nurses, I feel like, are overworked and underpaid frequently. So what can we do to have this conversation, start this conversation again? We're just, a growing adult population is only going to increase from here. I think this is not a new problem. It's been introduced, I understand, in the General Assembly several times, but I'm here to advocate for them. The less, I guess you could say, controversial piece of this bill as far as the background checks every 5 years and quarterly staff training. We can never have too much education for our staff. But again, I move that you, you've already adopted my substitute, but that we pass this bill, and I have several advocates here as well to speak to the bill.
Okay.
My name is Sam Cookage. I'm the Executive Director of Dignity for the Aged. We have 700 members in our organization, and we're trying to make people aware of the horrible conditions in nursing homes throughout Virginia. If you haven't been to a nursing home, I encourage you to visit one. We have more than 300 in the Commonwealth of Virginia. Some residents don't have anyone to visit it, and others do. But the problem is the family members are stressed out to the max, trying to ensure their loved ones get basic care. I'm one of those stressed out family members. The residents have grown accustomed to being ignored. Some can't see very well, some can't hear, but that is a real problem. A lot of people have just given up hope because they're told every day, get up, at 4 in the morning, because the CNA does not have enough time, so they get them up at 4 in the morning to begin their day. So imagine this, the light comes on, the bed covers are taken off, you're pulled up right, the CNA removes your clothes because it's time for your shower at 4 a.m. As a resident, if you learn that you complain, you will be turned combative, or you might not get a shower for another week. And all this while paying over $8,000 a month. So 3 issues are important when it comes to caring for the elderly. First, time, staffing, and dignity. Unfortunately, most nursing homes have become human factories, warehouses for the elderly that lack full-time staffing to provide residents with a care and treatment commensurate with the amount of money that they're spending and these institutions receive from Medicare and Medicaid. As a result, there isn't any time, there's not enough staff, and there definitely isn't any dignity. So being short-staffed creates this environment. There is little time to hear or address special needs or desires, concerns, or complaints. The staff has long forgotten you're an individual. You are a task that has to be accomplished as quickly as possible. And once they've attended to you, they have to move to the next resident. So the residents know that the staff's busy, and they start apologizing and getting up and trying to do things themselves. I meant to bring somebody with me, she couldn't today. Her name is Tammy Charnock. Her father died last month. He died because there was no one to take him to the bathroom. So he managed to get up out of his bed, get into his wheelchair, go to the bathroom. He was making it back, he was reaching his foot in to get into bed, and he tripped on the wheelchair and into his bed because a staff member was yelling at him, "You shouldn't be up." Well, long story short, he broke his foot. They had to bring him to the hospital. They brought him back. In the rush, they forgot to reconnect his oxygen. And they couldn't figure out why he couldn't breathe. And he died. Just because he couldn't go to the bathroom. So then you have the issues as family members. How do we report these things that are going on? So there's a process. You tell the aide, you tell the nurse, you tell everybody, okay? It doesn't matter. They do an investigation. 6 months later, they find out that you were right, but nothing changes. So, for example, my mother-in-law, she died a month ago as well. She lost 65 pounds because they stopped feeding her. They put the food in front of her, they never fed her. They gave her someone else's medication on several occasions. She fell 55 times. The last one resulted in 2 black eyes and abrasions on her forehead. I was shocked when I found it. I walked in, no one even told me. They said, "Oh, I'm sorry, we didn't see it. It happened during a shift change." My concerns were never addressed. And as a last resort, I'm somebody who follows the rules, but I said, I don't know what to do. I don't know what to do to help people. You know what we're gonna do? We're gonna stand on the street corner with signs. So that's exactly what we did, and that's where we got the most response. So we need help. We need these people to be helped. They're dying daily. Her picture, and people say, "Oh, we don't know." Her picture was on the front page of the Daily Press and the Richmond Dispatch. It's been on television. People know this stuff is happening. We need something to change. So it isn't, people know. In closing, sorry, I'm shaking. Done a lot of research, have a lot of people who really care. So, in closing, the Commonwealth of Virginia received an overall grade of D from the Families for Better Care Nursing Home Report Card for the 3rd year. The Commonwealth ranks 41st and 43rd in direct care staffing above average and direct care staffing per resident. Both are grades of F. Residents receive an average of 2 hours and 17 minutes of direct care per day. That's barely enough time to eat 3 meals, never mind basic hygiene, dressing, changing, showering, and toiletry. More than 65 homes in the state of Virginia are listed on this nursing home watch list. This watch list provides potential residents important information concerning actual harm findings with specific written deficiencies. It provides the number of days a resident receives below 2 hours of CNA per resident. It defines the characteristics of the residents. For example, if 96% of the residents need assistance transferring from a bed or a wheelchair, who needs assistance toileting if they're confined to a wheelchair? This watch list home also provides some amazing information because they're taking in between $10 and $21 million in revenue a year for 100 residents. And the residents can only receive 2 hours of care a day. The elderly are dying daily from neglect due to poor staffing. How can we possibly expect one CNA to take care of 20, 30, or more patients? Enough is enough. I was invited by Delegate Helsel a year ago to present my concerns to the Director of Virginia Department of Health, the Director of Policy and Research Division, the Division of Director of Long-Term Care Services, and the Associate Director for the Division of Licensing Programs. The response I received was this: we can't afford it, it's all about the money. If one facility can take in $1 million a month and cannot hire more than one CNA to care for 20 residents, we are in serious need of taking a closer look at where this money is being spent, because it's certainly not for caring for the residents. The CNAs and nursing staff are being set up for failure and are leaving this area of healthcare due to burnout. This bill needs to be passed so we can provide our loved ones the care they deserve. Let's take the first step and provide the care the elderly are already paying for. I don't even think we need more money. It's already there.
All right, I'm gonna have to, if you could hurry up a little bit. We're all on really tight, crazy schedules here, so, and we've got other people.
Please tell me my mother-in-law, Rose Kukich, and Tam Charnock's father did not die in vain. And some good can come out of their suffering, abuse, neglect, and death. Please pass this bill. Thank you.
Thank you very much. Anybody else? Yes, ma'am.
Well,
Hello,
Try
good
to be as
afternoon.
brief as you possibly can.
All right, my name is Erin Hines, and I work as a certified nursing assistant in Hampton Roads. And I've been working as a CNA for the past year and a half, and I became a CNA because of situations that arose with family members and friends. And I've witnessed a lack of care that's prevalent in many facilities and decided that I wanted to try and make a difference in the lives of our elderly. What I've experienced since I became a CNA has been very eye-opening. What I consider to be the most serious issue is that CNAs are given far more patients and residents than can be taken care of properly and with dignity. I'm a member of a CNA Facebook page which has 93,000 members, and the most talked about issue by far is the fact that these CNAs are often given 20, 30, and 40 plus patients to care for during a shift by themselves. They are tired, frustrated, overworked, underpaid, and go to work daily knowing that they will probably not be able to care for these residents the way they should be. And because of these conditions, CNAs are leaving the job right and left, and our elderly are suffering. The responsibilities of CNAs are numerous: showering, dressing, brushing teeth, brushing hair, feeding 3 meals, ambulating to the chair, the wheelchair, bed, bathroom, changing briefs, changing bed linens, making sure they have water to drink throughout the day. And now just imagine having to do all of these daily living activities for 20 plus patients a day or residents. This is impossible to complete with the time given. So that means that many residents across the state go without some of these basic needs on a daily basis. Call lights are going off, but there's no one to answer the call because there are usually a number of other residents needing attention also. So CNAs have a decision to make. Whose call will they answer? And who will have to wait another 30 minutes, 1 hour, or 2 hours? Who will have the dignity of using the bathroom properly, and who will have to sit in their own waste for who knows how long?
Okay, look, can you
Sure.
edit what's left? Because
All right.
I'm not trying to be rude, we've got 4,000 bills and.
All right. And CNAs are between a rock and a hard place when it comes between their supervisor's expectations and the family's expectations. Because families, understandably so, are upset at CNAs because they did not have a bath that day or other care has not taken place. But you cannot possibly do everything. And what are we supposed to tell these families who are paying $7,000 to $9,000 a month when they've entrusted us with their loved one and are told that their basic needs will be met? And for that reason and others, I support this bill.
Great, thank you very much. Anybody else want to say something? And again,
I
please.
promise to be short.
Yeah, please do.
My name is Vance Easton, I'm retired from Allen, York County. Since 1999, there's been 15 bills put in similar to the same subject, trying to come up with an answer. There's been 15 bills that have died in committee. And I can't say, I won't say pro or con on this bill, but this will answer all the problems we have, I don't know. But what I will say, if you go to Medicare.gov, while y'all are trying to figure this out, see the statistics you need to hear. Right now, these are for Virginia, it's not just in general. 15% of the long stay residents who need help with daily activities have increased. 20% of the residents have the ability to move decreased. It's gotten worse. 21% of the short stay residents have been re-hospitalized. And 54% of the low risk, long stay residents lost control of their bowels or their bladder. So while y'all trying to figure this out, these numbers are there. They're not numbers I made up. They came from Medicare. The other thing Medicare did put out, it's been 19 years since they put it out. They said nursing staff is directly related to the quality of care that residents experience.
Thank you. Anybody else? Yes, ma'am, really quickly.
Yes, very quickly. And I will be brief because I think the previous speakers and particularly the advocates have captured a very real picture. My name is Joni Latimer. I'm the State Long-Term Care Ombudsman. I've been kind of watching this process for years, and I just have to stand to endorse the good faith efforts of senators and delegates that have brought some kind of bill forward that would help us get a better handle, a number that we can work with in terms of trying to ensure that staffing is adequate. We really have kind of shied away, I think, from this for cost reasons, for workforce shortage reasons, and all the rest. But I do think at this point we have to re-examine that equation and change the set point on this, because frankly the cost of it is in the turnover and in certainly the deterioration of the quality of
speak in opposition to Senate Bill 397.
Yes, sir, Mr. Chairman, members of the committee, I'm Scott Johnson, I represent the Virginia Healthcare Association. I want to thank Senator Keegan for meeting with the members of our team, and she's certainly passionate, and we share that too. I mean, everybody wants the best quality health care for loved ones. I had a grandmother in a nursing home from 76 to 92, and I saw a whole lot over that time. But when you try to figure out what is the best solution for where we are, that's why we oppose the bill as we have in prior years. As the gentleman correctly quoted, you've seen a lot of bills to try to come up with a one-size-fits-all, and that is very costly. At this point, the physical impact statement on this bill has not been posted unless it's posted in a few minutes. And if I could share with you, this is a copy of the physical impact statement from a similar bill that Delegate Watson introduced in past years, and staff cost. And 60% of the nursing home patients are Medicaid patients, so that's our state tax dollars paying. Roughly 40% are private pay, and so those individuals are having to pay. The substitute, which we just saw when it was handed out to you, still has got some costly things in there, both with the staffing ratios. The criminal background checks are already done when the individuals are employed. That is part of our current regulations from the state. And of course, if you are licensed by a state board, then they're going to get reports from courts if somebody's convicted of a felony or certain misdemeanors. And the last line is troublesome too, because it would basically require us to give medication training to janitors and other individuals that are not even qualified to do that. What we would suggest that you respectfully consider is, Megan Healy in the Workforce Development Office has, at the governor's direction, looked at a lot of different workforce stuff across the state. We'd like to try to partner looking at our workforce, because that is something, you can give us all the money in the world, but if you don't have the people to hire that want to do the job or can do it really well and take good care of the loved ones. And so we would ask you to put together a work group and let us look at workforce in this arena and come back to you, because it's not a one-size solution fits all. We need to have flexibility, but we need to have good people to hire.
Mr. Chair, can I
Senator
ask
Studelman.
questions? If Mr. Johnson's so willing.
Yep.
Two different questions on two different parts of the bill. First, on the background checks, I see that the substitute would require them prior to the start of employment and every 5 years thereafter. You said that the background checks are currently covered by the regulations. What's the requirement and the timeline on those?
Mr. Chairman, the regulations require the background checks be done on everybody when they start employment, or for some people that are on contract when they're engaged, it has to be done then. But there's not a 5-year requirement.
So clarification on that real quick, Mr. Chairman, and then a different question. So clarification, so it's currently required before they start?
Yes, sir.
And so the difference here is the 5-year commitment?
Yes, sir.
I just want to make sure I was squared away on that. Sometimes we require the background checks at different times. The next question I have is regarding the ratios. I've been here for so many years, and I always know there's always a ratio bill over in the House, and I think this is the first time we've had one in the Senate, at least I can recall recently. So, are other states doing the ratios? Is that why the idea is so frequently overdone on the House?
Mr. Chairman, if I can, I'm going to ask April Payne to come up. She is a licensed nurse home administrator, works with the association. She can probably let me phone a friend to get you an expert.
There are some states that have staffing ratios. They vary vastly from state to state. But what also is important is that though every nursing facility follows federal guidelines, the majority of our regulations, they also have state-specific regulations. So some allow certain levels of care, and that's where those staffing ratios that's what they're tied to. So that's why we're saying the one-size-fits-all doesn't work. We have nursing centers that care needs are much higher, some that their acuity level, their care needs are much lower. And when you're prescribing just a basic staffing ratio, you could be underselling what they actually need in that building, or you could be spending additional funds for individuals who their reimbursement isn't even going to meet that threshold.
And Mr. Chair,
Senator Studelman.
thank you. I appreciate you coming up and answering these. So for the ratios that exist in other states, is their approach been similar to what is advocated here, which you just expressed concerns about, where it says, it's the 6-to-1 across the board, or have they done it variance?
So they're more of an hour ratio, but again, it's dependent upon the state license
how many, so I think I understood that part. And I think my final question, Mr. Chair.
Senator Solano.
Thank you. My final question is, how many states have these ratios?
I cannot answer the exact number, that.
Approximately, is it 10 or 40 or 25?
So when we last looked at this, it was less than 10. I will say that that every state in their General Assembly sessions have typically had bills, so a certain number of states have had bills introduced. We've had a few states in the recent who have removed the staffing ratios because they did not work, in that states.
I appreciate all that. Thank you, Mr. Chairman. Thank you.
You folks, I assume, heard Mr. Johnson's recommendation or suggestion for a recommendation. Would you all be in accord with that suggestion?
Yes, absolutely. I'm Dana Parsons, Vice
All
President,
right.
Legislative Council of Leading Age Virginia,
Okay.
and we would work with him on
All right.
work.
Next, you be in accord with that suggestion?
Andrew Lamar on behalf of the Virginia Nurses Association. We appreciate what the patient's getting at. We didn't really have a position on the bill, but we have big problems with workforce issues generally, and would love the opportunity
All right,
to.
so let me say,
look at this big picture.
let me say this. Appreciate the bill, fine bill, obviously great issue, impactful testimony, large, some undetermined but significant financial impact, other issues. Mr. Johnson has offered to work with you, with the stakeholder group, so I think that seems to be a good resolution on a temporary basis.
Mr. Chairman,
Senator
if
Dillon.
I may, just to speak to what I believe is your motion.
I was gonna let you make a motion.
Okay, well, that's great. So I will just say, Senator Kiggins and I have talked about this a little bit. This is a big problem, but it's more than just the staffing ratios. I worry about staffing ratios because people call in sick. Things happen, it's hard to employ. Holding businesses accountable for staffing ratios that they may not have all the controls over concerns me. But I think we need to get innovative. I think we do need to talk about what are the obstacles to having the workforce that we need. For my nursing homes, some of the things I've heard is that they can't get MAs there. They don't have their own transportation, the bus doesn't go there. That we've gotta find out creative ways that we can get them there. We need to drop the workforce training back into the high schools, so that certified nurse assistant certification is completed before you finish high school, with them doing internships in nursing homes in the community, so we can make a easy transition into that workforce. I think there's a lot of opportunities for us to fix the problem, which is egregious, but I think that this one bill with one action is probably going to cause more harm and challenges than good. So I would like to propose a motion that we consider making this a work group to work in conjunction with the healthcare workforce initiative that Megan Healy is working on at Workforce to figure out all the variables. I think that we should have advocates on that. I think we should have CNAs and advocates and stakeholders, because in a hospital setting, you get patients on your advisory committee for the hospital because they have input that other people don't have. So with the understanding that we can write that up into some language later, I'm wondering if the patron would be amenable to that substitution.
Yes, I would be amenable to that, with introduction next year.
We've got, you made a
moved.
motion. All right, so we've got a motion which Senator Barker has just seconded, and that will be the recommendation of the subcommittee to the full committee. So all in favor say aye. Aye. Opposed? Barker's obviously yes.
I'll be right back.
Senator Locke. Next on the sign-up sheet.
Mr. Chairman, I have two bills. Take Senate Bill
946 first. Senate Bill 946.
Okay, Senate Bill 946. 946 is asking or directing the Board of Medical Assistance Services to amend the state plan for medical assistance services to include a provision for the payment of medical assistance for antepartum, intrapartum, and postpartum services provided to a pregnant person by a doula. And specifically, there's a great disparity between the maternal mortality rates of white and black women. Studies have shown that Black women experience 44 deaths per every 100,000 live births, while for white women it amasses to 13 deaths per every 100,000. So doulas help to reduce the impacts of racism and racial biases in healthcare for pregnant women of color by providing individually tailored, culturally appropriate, and patient-centered care and advocacy. And doulas support childbearing people in pregnancy, birth, and postpartum to reduce rates of cesarean deliveries, premature births, and the likelihood of postpartum depression. So by requiring Medicaid to cover doulas, the healthcare system would promote more equity in regards to race and economic welfare. So that's the purpose of requiring this. That's the purpose of the bill.
Okay. Just looked up what a doula was.
No,
You
I'm
would already.
familiar.
You're familiar. Okay.
It's better for me not to comment.
Okay. All right, anybody here to speak in support of Senate Bill 946? Yes, please.
Mr. Chair, thanks for the opportunity to speak. My name is Freddie Mejia. I'm with the Commonwealth Institute for Fiscal Analysis. I'm a healthcare policy analyst. Senator Locke really said it all. There are some serious racial equity considerations with this doula care, and we full-heartedly support this bill. I would also mention that New Virginia majorities and Progress Virginia have asked me to also mention my names in support.
Okay, great. Next.
Good evening, Chairman, members of the committee, Sarah Carolino with the Virginia Poverty Law Center. We also support this bill. We think just supporting this population in this way is incredibly important. If you were able to go to any of the governor's listening tours on his maternal child health tour around the state, the stories told were heartbreaking, and many of them were related to just the lack of communication and the misses that were occurring between the patients and their physicians and their care providers. And the doula can play a really important role there, and so we support this bill. Thank you.
Great. Anybody else speak in favor? Anybody who wants to speak against 946? Senate Bill 946.
I just want to speak briefly.
Sure, go ahead.
So this applies to everyone, everywhere in Virginia, correct?
Correct.
So I think it's not, I mean, it might help some part of the population more than other parts, but I think this is something that's probably going to help mothers from Lee to Virginia Beach. So I move that, has finance asked for it?
That would go to full committee.
Alright, well then I'll recommend report and then full committee can decide what they want. And Senator Donovan seconds the motion.
All right, it's been moved and seconded that we recommend reporting Senate Bill 946. All in favor say aye.
Aye.
Aye. Opposed?
Okay, so next I have Senate Bill 993, and there is a substitute.
Okay. Since law moves to substitute, Senator Barker seconds. No substitutes in front of us.
So,
Thanks for the warning.
okay, Senate Bill 993 has to do with the state health commissioner and qualifications for local health directors and state health commissioner. This came at the request of actually a constituent of mine who has a PhD in public health. And basically public health is certainly a different field than medicine. And public health as a discipline is a field of practice that's interdisciplinary and is an array of knowledge, skills, and abilities, including biostatistics, epidemiology, psychology, sociology, anthropology, and many other fields. And basically what this is asking for is that if one is going to serve as the director for the state health, as a state health commissioner or a local health director, that it not necessarily just be an MD, that it could be someone who has a doctorate in public health, as well as could be someone who has a master's in public health, who has the experience in those fields.
Mr. Chair, may I ask a question?
Yes, Senator Suderline.
So, Senator Locke, I approach these things basically with the idea the governor got elected. We're involved in confirming them. I
question is, I don't understand what a doctoral degree in the area of public health is if it's not a degree in public health itself. So just so I understand, what is that?
Senator Locker,
Would you like to answer my question?
I can.
Oh, please do.
So there are three main graduate degrees in public health. A Doctor of Philosophy.
Tell us who you are, just
I'm
for
Dr. Leslie Hogan.
protocol.
I'm from
Okay.
John, Virginia.
Thank you.
And so having a PhD in public health is a research-based degree. So you've done a doctoral dissertation, a research study in public health, and you've gone through all the coursework required to be an administrator, a leader in public health. The practical degree is the Doctor in Public Health, which is basically an extension of the Master's in Public Health degree.
Answer your question.
Yeah, I think it's not necessary to have the word doctoral degree in the area of public health, but like I said, I'm for the concept, so unless someone else has an issue with it.
Gonna have to ultimately go to finance if you're creating a department, so.
No, we're not. It's our same job that's
Departments
already
already
there.
exist.
She's just doing the, see the new language, you can see the new language.
No one's against, I'm ready to report.
Shoot.
No one's coming up to speak against?
Anybody against?
All right, I move to.
Oh, wait, yes, sorry.
I'm not necessarily, I'm Bob Hicks, Deputy Commissioner.
Yeah, no, Bob.
For Community Health Services. I have oversight of all.
I'm sorry, yes, ma'am. Which favor?
So I do speak in favor of this.
Oh, I'm sorry, I thought you said ask for a favor. Go ahead.
May I speak in
What can we do
favor
for you?
first before?
That's the favor.
You're on a roll.
Okay, that's great. So this code,
Just let you know,
I'll be brief.
time is precious and you're on a roll, so. Okay.
I don't like long-windedness. So this law has not been updated since 1979. So in 40 years, the public health system has dramatically evolved. And this just expands, puts on a little thing to the eligibility to be a state health commissioner to include experience, so any experience in public health or a degree in public health. So the substitute also gives the flexibility to the Department of Health for a local health director to also have a degree in public health. So it is quite a conundrum to me that having a degree in public health, there's 7 schools of public health in Virginia, and the 150 or so that matriculate every year, they would not be eligible to serve in these roles after being educated in public health. Currently, right now, there are 19 out of 35 health districts that do not have a direct director serving their communities. That's 3.5 million people in Virginia that don't have a single provider director covering their health district. So that puts the public health system in a fragile state. And this would just expand the opportunity to hire qualified people who are experienced and trained in public health to serve their communities.
What do other states do?
So Virginia is only one of 5 states that restricts to medical doctors. So I could go to North Carolina, Maryland. So Virginia, Georgia, West Virginia, Mississippi, and DC.
Senator Sasslaw.
How many states have an MD versus how many states have a PhD?
So 45 states allow for degree
How many of them
professionals.
have either, what's the ratio between states that have an MD as opposed to a PhD or vice versa?
So MD only are 5 states.
No, you're not answering my question. How many of the 50 states currently have an MD or a
45.
45 states currently have a medical doctor in place
No.
as a director. You understand the question I'm asking you?
No.
I'm not really clear.
He wants to know who currently
There's 50
holds those
states.
positions.
There's currently 50 states. How many of the states have an MD heading in? How many states have a PhD heading in?
I would have to do that research
Okay.
for state health commissioner.
He's really a big sweetheart, so don't let him.
But I don't know if you remember my son Quentin. He was age 2 years ago, and he said, "Say hello to you."
There you go. See?
There's the favorite.
I have one.
All right, I'm sorry, go ahead, Senator Dunham.
Just for the patron, is sanitary science still something?
The what name?
The word, the language sanitary science? Or is is that something we should just start, I've never heard of that.
That's currently in the
Yeah,
code.
but would just before we go to committee, will you check and see if that just is something that needs to be updated in the code? It seems not anything I know.
Okay. All right, thank you. Bob?
Mr. Chairman, Committee, I'm Bob Hicks, I'm Deputy Commissioner for Community Health Services. I have oversight of all the local health departments in the state, except for two, Fairfax and Arlington, that are independent local health departments. We're consolidated into 35 health districts. Some of those have unified leadership. All of them have a medical doctor in charge of them, except for two. We have a vacancy in Eastern Shore, and we have a vacancy in Peninsula Hampton, from where Dr. Oakland. We're in the final negotiations with that for a medical director. I do have one of my local physicians here, who's a medical director, also an MPH. 62% of our health directors have MPH in public health.
I'm Dr. Stephen Herring. I'm board certified in public health. And there's lots of different titles when I talk to my colleagues across the country. Some of us are called health officials, health directors, some are called health strategists. But I look at my role, the way I'm treating my community is the community's family physician. So when there's Ebola, the law enforcement's asking me, how do we prevent our doctor, how do we prevent the sheriff's deputies and the police officers in the street from having a risk? When there's coronavirus, the hospitals call me because they understand I've worked in a clinic. How do they protect their staff? When the superintendent has an issue or one of the principals has an issue of an animal infestation, they're asking me because they understand that I have their interest in that. And what they're looking at me differently, I think, than the colleagues that I have that are health directors that are not MDs, is that I have a certain connection with the medical community. And I understand what doctors are going through in the emergency department. The other important thing to remember is that even if a director is not a medical doctor, you still need a medical doctor to run the health department, to oversee the nurse practitioners, their work, to prescribe for prophylaxis, for instance, if there's a meningitis or a pertussis outbreak. And so there's a lot of different reasons that having a medical doctor actually is cost effective for Virginia Department of Health. You don't need two positions. You don't need a director and then a doctor. Instead, a doctor's a service.
Okay. Anybody else want to contribute to the discussion?
I'd like to make a motion.
All right, Senator Sudalan.
I move that the subcommittee recommend report by the full committee.
Okay. Senator Barker, I'll second that.
He's got that master's. Thank you.
Actually, I better not do that. Let me second it.
I'll second it.
Okay, the motion is that we recommend to the full committee that we report Senate Bill 993. All those in favor say aye. Aye. And Barker will abstain.
I'm gonna abstain. I think I'm in favor of it. I just wanna sort out a few things I missed while I was in another committee.
All right, thank you.
Senator Deeds.
Two bills have already come back for the week.
Yeah, we've taken a lot for it.
49, 10, 15,
Okay.
738 was the first bill I want to take out. I think we have a substitute, and it ought to be a substitute that bears today's date, 1/28. It's been the subject to a whole lot of negotiation. I have, at 738 with the substitute.
Let me just ask Senator Deeds, these are the last two we have?
Well, I have three bills.
Or you've got three? You've got three? Four. Okay. Yeah, we have nothing on the docket today, but he wants to do these today, so let's.
I've got a couple of
Yeah,
witnesses here.
let's do Senator Deeds and then we'll reevaluate after that. I've got to go down to Ag and present a bill, so you're in charge.
738 with the substitute. Now, the high bed census is a well-publicized problem. One of the contributing factors is a number of intoxicated individuals who are TDO to state facilities. Somewhere around 20% of the people that are TDO are just, they're under the influence of drugs or alcohol. A number of those individuals are released from facility once they're sobered up. It's clear they don't need to be hospitalized, they're released. One of the options available to healthcare practitioners that is underutilized is medical TDO. Emergency room physicians brought this bill to me, and the stakeholders, all sorts of stakeholders, have worked hard to develop the substitute. I understand there's peace in the valley. The bill before you clarifies that medical TDO may be used for an intoxicated patient. If the person is transported under an emergency custody order, the ECO will terminate at the issuance of the medical TDO, at which point the individual is no longer in the custody of law enforcement. Under current law, the medical TDO is 24 hours. The bill doesn't adjust that time. The bill directs, and the final part, directs the Department of Behavioral Health and Developmental Services to convene a work group to develop policies and procedures by July 1 in order to educate and inform healthcare providers, magistrates, and law enforcement about how this tool will be used in practice. And all of these groups have been, that healthcare providers, magistrates, law enforcement, everybody's been at the table working this substitute language out. Amy Seibert is here, if there are any questions, but I think that there's peace in the valley on this.
Mr. Chairman, I'll just comment, this is how it used to be.
Let me read this one. So what's this basically changing?
What it's changing, Mr. Chair, is it's making it more clear that you can use the medical TDO as a way to keep that person who's just intoxicated or under the influence of drugs out of a psychiatric hospital, and hopefully relieve some of the pressure with the bed crisis. You know, right now, when you look at any of that medical literature out there, anything more than 85% census puts people at risk. And I'll tell you the truth, the Northern Virginia Institute of Mental Health and at Central State, law enforcement officers are called just about every day because of an assault that's directly related to the oversubscription of those beds. That's why this is an important legislation. Medical TDO can keep those people out of the hospitals and get them released quicker. Most of them aren't, they're admitted to hospitals, but they're gone within 24 hours. They're taking a valuable bed.
So, Mr. Chairman, question for the patron. To help clarify, I think what you're saying is the TDO is usually 72 hours.
The TDO can be up to 72 hours.
Up to 72 hours, and this is a way for somebody to be held for 24 hours if medical discretion advises that that's all is necessary for the protection of the individual.
That is correct.
Now, I'm reading that one, pages 6 and 7.
That is correct. And Amy can handle more technical questions. I mean, I hope I didn't mess it up.
No, that's right. This is actually Dr. Drin Sakura, who is a ER physician, so she can also answer any questions about how the medical TDO works and how we think it could help if you guys have any particular questions, Senator Saslow.
And so, as Senator Dean said, you know, this is our way of kind of working with all of these different groups, the sheriffs, the Department of Behavioral Health, VHHA, in terms of what can we do to help with the bed capacity issue. And so one way we talked about was with these intoxicated patients, and not just alcohol intoxication, and not just your illicit drugs. We're talking also about the overdoses on Tylenol, Benadryl, okay? And so what's happening is that they come in, you've got, they have to be medically cleared, right, in order to go to a psychiatric facility. So what that means is sometimes sitting there for 8-10 hours at a time. But now, right now with, you know, they should be under, ideally, a medical TDO during that time, and there shouldn't be a process going, looking at psychiatric facilities during that time, otherwise they'll end up in the state hospital. So the whole idea is stopping that medical ECO, getting a medical TDO, a mental health ECO, getting a medical TDO, and then once the person is cleared from our standpoint, asking them, one, are they still voluntary? Because involuntary. If there's voluntary now, things change, right? Things shift. They no longer need a mental health ECO. Two, is the problem still active? As Senator Dean said, so a lot of patients, sometimes they unfortunately malinger, and they end up saying, you know, they are intoxicated. They say, yes, I'm suicidal. Sober up, and sometimes things change, right? you know, I'm no longer a suicidal, homicidal, things change. You didn't have to get a bed for them at a state hospital, so things do change. And then if they do need it, then we get get another mental health ECO.
Mr. Chairman, in what bed are you keeping them for the 24 hours?
So it's not, ideally it wouldn't be 24 hours, it's an ER bed, right? And so that's the compromise we made, is that it would be, you have up to 24 hours.
Well, when you get a temporary detention order,
Mm-hmm.
somebody files for one against their
Mhm.
relative, whatever, where do they go?
Once a temporary detention order is
Is
issued, they're going to a regular hospital. If the hospital got space, if not space, the better last resort legislation puts them in a state hospital. And the whole purpose of this bill, and frankly the next bill, is to relieve pressure on the state hospitals.
But to a
By doing-
psychiatric
by-
bed.
That's right.
To get them into a psychiatric setting?
Well, people that are intoxicated might not need a
Right,
psychiatric
yeah, I
setting.
understand.
That's why, it's felt like if you can keep them in the emergency room until they sober up, you can figure out if they need
Whether they need anything.
whether they need anything else, and then they don't need a hospital bed at all.
And then they release them?
Yes, around 20% of the people that are TDO'd right now are released within 24 hours because they're intoxicated or they're under the influence of drugs.
Mr. Chairman, follow-up question.
Senator.
Does this require staffing from the police department or sheriff's department in the ER for that 24-hour period?
I think the
That's
reason why there's
different
peace in
than-
the valley is that this
It relieves staffing.
That's what I was saying.
We like the bill, and the work group that someone talked about all this is a good alternative. If you may know that back in Memorial Day and 4th of July, the state hospital filled up, these people backed up in the emergency room. We had deputy sheriffs sitting there for 10 and 20 hours. We actually had to change shifts. This bill takes care of that. We're gonna turn them over to the hospital. It's a medical situation, it's not a public safety situation.
And part of the work group is how do we make it safe in the department, you know, as well. So getting the hospital security also on board with this is gonna be a key feature of this.
Okay. Hold on. Is there anyone in opposition to the bill? All right.
Move to report.
I've got a question.
Senator Sewell.
And I think the Sheriff's Association might be able to speak to it. I had to step out. Are the police chiefs now also, have you heard, have either of you heard?
I haven't heard, but we've all been working on it for the last 3 days, and they've been involved in the email, but I'm not.
There's a second, the substitute that it's 1:28, 1 PM or something, represents a compromise. Everybody's been around the table working this out. So I think there's complete peace in the valley on this bill.
Okay.
Primarily, a large reason, once the medical TDO is issued, the law enforcement's relieved of any obligation for custody.
On line 113, it said ending law enforcement custody.
That's right.
That makes it.
So when John's talking about relieving pressure on his manpower, that's what he's talking about.
I just don't hear from my police, I hear from my sheriffs a lot. I don't hear from my police chiefs very frequently, but I heard from them on that, so I just wanted to see if they had anything. Thank you both.
Move to report.
All right, I'll second that. All those in favor of reporting the bill, say aye.
Aye.
Okay, and Senator Barker, I'm guessing, change it later on, but I guess it's Senator Barker, Senator Lewis, supported the bill.
Okay, Senate Bill 739, there was also a substitute. You'll recall back in 2014, we passed a psychiatric bed registry to give people a tool to find beds. Well, it's never worked quite the way we wanted it. And I hear every day from law enforcement and from, not every day, but certainly every few weeks, I hear from law enforcement or CSP workers that, it's not functioning the way it was. So, and last year, we passed Senate Bill 1418, directing the Secretary of Health and Human Resources, to convene a work group to study the issue and come up with some recommendations. That was a broader broader to do with the high bed census. One of the topics discussed was the need for data collection, which is complicated by a whole lot of issues, including the psychiatric bed registry. One of the non-consensus recommendations of the work group was to enhance the psychiatric bed registry to improve its usefulness for clinicians searching for a bed in a mental health crisis and for data collection purposes. The Joint Subcommittee to Study Mental Health Services in the 21st Century voted to move forward with the legislation, even though it was non-consensus. So the bill, as originally introduced, included a number of data collection points and added them to 37.2-308.1.
It seems you changed all that.
I've changed all that because we just decided it was premature to put all that in the code. So as it's, and here's the problem. I mean, this is a very real problem. I'm not willing to wait until next year to fix the bed registry, and I want to look for ways in the budget to do that.
Mr. Chair, unless there's someone that doesn't like this approach, I'm ready to move to recommend.
All this bill's doing is setting up essentially a study type.
That's
thing
it.
to work
That's
with.
it.
Yeah, I'm ready to move to
All right.
report then.
Second.
All right, it's been moved and seconded, and we recommend reporting to the full committee, the Senate Bill 379. All those in favor say aye.
Aye.
Opposed?
Okay.
And vote Parker and Linwood in favor of the bill.
Okay, Senate Bill 1046 adds clinical social workers to a number of code sections that list out healthcare providers, primarily. It's 1046.
1046?
Yes. It's related to, primarily related to access to records, recommendations for TDOs. For example, it permits a clinical social worker to withhold records if the release would endanger the life or physical safety of the patient or other person, for adults or minors. The current statute limits that ability to a physician or clinical psychologist. And the world we live in, we just don't have enough psychologists. We don't have psychiatrists. So the clinical social workers are doing a whole lot of work. Another instance, it adds clinical social workers to a list of professionals who may examine a prisoner subject to a TDO. You know, they're the people doing this work, and so it addresses reality. But I've got Joe Lynch here, who can address why the clinical social workers want to be included in this list, the practical reasons. But from my standpoint, they're the ones that are doing a whole lot of the work because we just don't have the workforce in behavioral health, and so that's the reason for the bill. But Mr. Lynch can address it as well.
Gathered some of the statistics on how many board certified psychiatrists do we have in Virginia, how many clinical psychologists do we have, and then look at clinical social workers and licensed professional counselors and marriage and family therapists. And you're 3 times more likely to be seeing one of the professionals not named in the statute. And I'll give you an example of how this became a problem. Before I retired in my practice, we had a licensed professional counselor who was seeing a 9-year-old girl as a patient. The parents were divorced. The child reported to the therapist that she'd be sexually abused by the father on the visits. And the therapist reported this to Child Protective Services, documented everything in the record. Well, the next day, the father asked for a complete copy of the record. And since we were not named in the statute, technically our attorney said, you have to turn it over. And we believed it would have been harmful for the father to read all the things that the child had reported about being sexually abused. And I found a way to send the record to the juvenile court so that they could decide whether or not the father would see it.
So essentially what you're doing is currently physicians and clinical psychologists can disclose or withhold. You're just adding social workers. Okay.
And if you wanted to add other counselors and marriage and family therapists, you could. I'm not speaking for them.
They can get their own bill.
All right, anyone here desire to speak in favor of the bill? Is there any opposition to the bill? All right. It's been moved and seconded that Senate Bill 1046